Okay, so up until this point, we've been talking about some of VA-CAUSAL's rapid response projects. Now we're going to transition to talk about other use case projects that leverage various sources of data in the VA. So our next talk is going to focus on the use of EHR data to emulate target trials of bariatric surgery and cardiovascular events. This was one of the first projects conducted under our program, and it's a project from which we learned a lot about the strengths and limitations of EHR data to answer certain questions. And so for this talk, we're going to be hearing from Dr. Arin Madenci. So Dr. Madenci is a clinician scientist who is jointly appointed as assistant professor in epidemiology at HSPH and in surgery at Harvard Medical School. He's a member of the CAUSALab and a staff surgeon at Boston Children's Hospital. And through his research, he applies causal inference methods to generate actionable evidence for patients, for clinicians, and other decision makers in high-impact clinical settings. His work involves target trial emulation and using causal inference methods to maximize results from randomized trials. So welcome, Dr. Madenci.
Hi, everyone. Thanks for joining us this morning, and I appreciate your interest in this topic. As Barbara said, we'll switch gears a little bit and talk about a different topic, in particular bariatric surgery and the bigger picture of what we learned from completing this study in the VA. So to get started, I'll very briefly introduce bariatric surgery at a very high level. So this generally involves one of 3 or more operations to help promote weight loss. The most common now in this day and age are gastric sleeve and gastric bypass. And I think this question now is seen in 2025 through the lens of medications that can help achieve weight loss is increasingly important as we think about the risks and benefits of that treatment and of bariatric surgery. So prior studies of bariatric surgery and its effect on cardiovascular disease is something that I'd like to start by reviewing because we'll see the VA data through that lens. We know that for obese patients with type 2 diabetes, in randomized trial settings, bariatric surgery and intensive medical therapy leads to a reduction in hyperglycemia and often a cure of diabetes. The effect of bariatric surgery on cardiovascular disease is much less clear. And that has not been evaluated intentionally, directly, through randomized trials. However, a number of observational analyses have been performed, and I'll review some of those results before showing our target trial emulation and results. So over 10 years ago, the Scandinavian study on obesity demonstrated with surgery, meaning bariatric surgery, versus a control group, there was a reduction in the risk of cardiovascular events and a hazard ratio of approximately 0.83. More recently, in 2018, another observational study demonstrated that in a matched trial design among matched patients, there was a hazard ratio of 0.58 associated with bariatric surgery compared with matched non-surgical patients, again for, in this case, coronary artery disease. And in each of these cases, the definition of cardiovascular events is slightly different, but overall similar. And this is over a 7-year follow-up. A few years later, similar matched study design, non-surgery controls were found to have higher cumulative incidence of cardiovascular disease, hazard ratio of around 0.6 relative to metabolic, which is a synonym for bariatric surgery. That's over 8-year follow-up. And there's been some conflicting data, though, and I'll present two conflicting examples. And the goal with our research was to figure out how can we synthesize a number of conflicting results. Also mentioned that to have hazard ratios that extreme, or risk ratios that extreme, it takes, I think, a lot of strong evidence, stronger than was even provided. And so this is a study of synthetic controls who underwent an orthopedic surgery as kind of a stand-in for a control, which is another method that's sometimes used. And this group demonstrated from the pharmacoepidemiology group hazard ratio near the null with synthetic controls compared with major cardiovascular events with a hazard ratio of 0.6, similar to prior observational studies, the same data set over 5-year follow-up, indicating that perhaps this 0.6 risk reduction or hazard ratio is overly extreme. Finally, there was a recent pooled analysis from 4 randomized trials that were designed to study diabetes outcomes among diabetic patients who underwent bariatric surgery over a 12-year follow-up. And what that showed was that there were no differences in major cardiovascular adverse events. Now, these studies were not intentionally powered to study cardiovascular events. These were pooled together from 4 different studies. But you can see that in the left-hand column, intensive medical therapies as not including medications. This was sort of in an era before that which we're in now, compared to the bariatric surgery. All of the cardiovascular outcomes are essentially the same between groups. So this is conflicting data from the randomized sphere, from different designs, and so we try to bridge that gap and understand that a little better. So the most important thing to do to start is to specify our target trial. The important thing here, and what I'd like to emphasize as really a strength of the Veterans Affairs collaboration and data, is that this is a very complex clinical question that I think has been really oversimplified at times in other analyses. The reason for that is that surgery is more than just a point intervention that happens on one day and time. Rather, we know that the median duration from initial clinic date to getting an operation is months and months, and sometimes longer. That's because of a complete preoperative evaluation, psychiatric, nutritional, cancer screening, social screening, and laboratory and cardiovascular testing. So you can see here an intensive checklist. And the checklist continues smoking cessation counseling and other interventions, as you can see. So we have to take that into account in our target trial. And so we have to start at, as always, at time 0, the time when treatment was assigned in the medical records, or it would be assigned in our hypothetical randomized trial. So if we think about bariatric surgery as a point intervention, we can try to do this, and we would say that all patients would have to complete all the preoperative steps and then either have surgery or don't have surgery during follow-up. Another way to think about this would to think of things as a strategy rather than point intervention, and we would randomize patients in our target trial to undergo all the preoperative components on that checklist that I showed, and then either undergo bariatric surgery or not. So to say this in another way, complete all the interventions, undergo bariatric surgery, or don't. And then for the strategy, undergo all the preoperative components for at least 6 months, and then undergo bariatric surgery at some time during the next 6 months, or do not initiate this entire strategy. And then shown visually, you can see that in one of these trials, the second one, randomization occurs here. There's a preoperative period, operation, postoperative period, or randomization starts after a preoperative period. This will also be taken into consideration in our design. The eligibility criteria are what you would expect obese individuals who were eligible for bariatric surgery and had type 2 diabetes to align our study with prior randomized trials and had not had a prior cardiovascular event. But there are some specifics here as well. Additional eligibility criteria for a trial in which all participants had completed the preoperative procedures, well, they wouldn't get a surgery if they were still smoking. So we add that to our eligibility criteria, and they would have to complete all these preoperative components. For trial 2, we didn't make a restriction on smoking status because that would be part of the preoperative checklist of criteria to complete. Our outcome definition was cardiovascular event. We had 7 years of follow-up, and our causal contrast was a per protocol effect. We used methods similar to those previously described, pooled logistic model for inverse probability weighting with censoring when, cloning and censoring when individuals deviated from their assigned strategy. So I'll briefly describe some challenges which we learned from. I think are important in highlighting issues with prior studies. Everyone who completes preoperative component essentially receives surgery. One way to understand this in prior studies is to say that there is no direct effect to assume there is no direct effect of preoperative changes like smoking cessation and screening on outcome. And this is, I think, much too strong of an assumption based on our substantive knowledge. Additionally, over the year prior to surgery, you can see that there, in the group of those who actually had surgery, there's reductions in hemoglobin A1C, BMI, blood pressure, triglyceride levels, not seen in those who had just medical treatments. And finally, there was insufficient overlap in covariates. So patients who had those trajectories weren't seen in the group who did not have surgery. Finally, there can be differential measurements. So we see that among those who ended up undergoing a surgery, 32% were diagnosed with sleep apnea over the prior year, same with osteoarthritis, hypertension, and dyslipidemia. That's because of all those screening procedures. That's not seen in the no surgery group. So for our emulation plan, we had to strongly restrict to individuals who had not had an increase in BMI by more than 2 kilograms per meter squared, and adjusted for these covariate histories, but could not adjust for changes in covariates over time in the second trial. We completed the analysis plan as I described, and then I'll briefly show some results. So we included over 2.3 million individuals with a BMI or initially considered for inclusion over 35. And for the first trial, there were over 8,000 eligible individuals, over 400 underwent surgery, similar numbers for the second trial. I'll show our results here. So for BMI, we had a positive control, which made sense. At the end of 5-year follow-up, there's a reduction in BMI in the surgery group in trial 1 of the point intervention, same in trial 2 of the strategy of -3 and -2 kilograms per meter squared. Hemoglobin A1C, likewise, there was a decrease in the surgery group compared with the no surgery group. But for cardiovascular events, and I'll show this graphically, they're relatively similar between groups at the end of a 7-year period. We did try to replicate a conventional observational analysis in which we demonstrated that there was a reduction in risk with surgery compared with no surgery that did not account for all of those assumptions and concerns that I had shown previously. So as a final slide, I'll state that this was a very challenging study to emulate. This couldn't have been done in any other system lacking all the data that the Veterans Affairs system has. And specifying and completing this emulation was able to highlight all the assumptions of prior studies, all the imperfections of our own studies and prior studies, and better understand the real effect of bariatric surgery on cardiovascular disease. This improves our understanding of observational data analyses and what questions can be answered, and helps point to new and important substantive areas for target trial emulation. Thanks very much for your attention.